Dr. Khanna? Hello?
Hello.
So you can, yeah, good morning.
Good morning, Dr. Khanna. This is Dr.
Yeah,
Tyagi.
good morning. Can you hear us?
Yes, we can hear you loud and clear.
Yes, sir. Good morning.
Tell us about the case.
Okay, so we have a very interesting. I have Dr. Erilan with me, and he's going to be telling you about the case. This is a very interesting 75-year-old gentleman where we had a CT which showed multiple CTOs and a calcified lesion, but when we did an angio today, we found there is a complete occlusion. And I'm going to be showing you something after this, after Dr. Erilan tells you about the case.
Yeah. Good morning to everyone at India Live. This is from MMM Cath Lab 2, the second peripheral case.
Yeah, good morning.
We have a 73-year-old gentleman, diabetic and hypertensive. He had an old inferior wall MI for which he had a PTCA and stenting to OM in 1999, and then again PTCA stenting to RCA in 2009. He has mild LV dysfunction. Renal parameters are normal. He has history of claudication of the upper two-thirds of calf since last 5 months. He is in Fontaine's stage 2B or Rutherford's grade 1 category 3. He had an ABI of 0.7 and his CT angio showed a task type A lesion in the CT. You can see the CT. But to a surprise, when we did an angio today, it was totally occluded SFA. Over to Dr. Khanna to show you the angio pictures.
Okay, can I go
first
and show you the first one? Can I have the first picture? Okay, so we went crossover from right to left, and this is the angiogram which we saw. There is a total occlusion of the superficial femoral artery just after the origin. You can see there is a bifurcation of the common femoral and there is a good profunda femoris. Can you play this? And then the superficial femoral actually constitutes as above knee popliteal. And next. And what we see is that there is a good popliteal bifurcation into tibioperoneal trunk and the anterior tibial artery, but the flow is very, very slow because it's a collateral flow from the profunda. Next. Go next. Next. Okay, so then we took a wire and we have tried to wire the superficial femoral artery for the total occlusion. Next. And we got the progress of the wire, but you can see it's a calcified lesion and it has gone subintimally, but that is okay, it's going with the loop, and our whole issue here is to get back to the true lumen near the popliteal, because there was no way the wire was going luminally. We even tried a coronary slippery wires and also a fielder XT wire, but it doesn't go. So now you can see that we are near the point where the artery reconstitutes, but next. But if you can see closely here that we are subintimal and our whole task is to get back to the true lumen. Next. So we are trying, this is a curved, we first took a diagnostic 5 French Cordis right coronary catheter, then we have changed that to a Terumo catheter which is 4 French and angled. Next. Go next. 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 So just hold on here. So we know up till this point we are in the true lumen because we can go into the branches And just beyond that, we have gone subintimally, and we need to get back to the true lumen at the right place, next place. So once this looks like this is definitely in the false lumen, because you can see it goes out of the vessel. Silhouette, next. And that is where we are here right now. And we are trying now with a angle thermocatheter. The good thing is that we have a backflow. Can you show it here? We have got a backflow in the catheter. That means the false and the true lumen are communicating, and it won't be very difficult to find the re-entry into the true lumen. Now, if we had a re-entry catheter, or if we had something like a, an outback catheter, we could have gone into the true lumen very precisely. But here we do not have any hardware to get into the true lumen, so we'll try our conventional technique, which is to actually take an angle thermo wire and an angle thermo catheter and try to get back to the true lumen with the roadmap in position so that we know exactly where to go. So we are here, and I would like your suggestions here, and then we proceed and get back to the true lumen. So it's like a long chronic CTO, and it will take time, like in coronaries, it may be very fast, or it will take time. And once we do that, we are going to dilate it with a balloon, maybe do a drug-eluting balloon, and follow it by a spot stenting.
This is Sri Iyer. Yeah, I understand the difficulty from this approach. I mean, this is one of those situations where you always worry about extending the plane of the false lumen and going all the way down to the popliteal versus a popliteal approach. This is a good case because you got a very good length of suprapopliteal segment right from the adductor canal all the way down. Not that I'm suggesting you do now, because it's logistically quite difficult turning the patient around, etc. But that is something you should not compromise, because the more you extend your false lumen, the more difficult it is going to be to get into the popliteal artery. It's a series that we published more than 25 years ago. Of 90%, I think, of the patients who were...
I totally agree with that because, once we started, as you saw in the CT, we were not anticipating this because there were just focal stenosis in the mid segment.
True.
But now, once we know it's a very long segment, we don't want to turn him around and do a popliteal puncture and go retrograde. But I am very sure, because I am getting a flow, that there is a communication between the false and the true lumen. And it's only a matter of time where I will find the true lumen and get back much above the knee joint, maybe just near the adductor canal.
Good morning, Dr. Khanna. This Tarun Madan here, sir. In the supine position also, sir, if we can puncture the upper part of the popliteal femoral junction and just introduce a needle, don't put a sheath, cross it with a 035 wire in the supine position from the medial part of the thigh, and then exteriorize that wire, leave that needle in place, and then once you exteriorize the wire, balloon it, and then occlude the puncture area with the balloon itself.
Yeah, that is a technique that has been
my
popularized.
bailout approach would be that.
By the group in Leipzig, these are the guys.
But my bailout approach would be that.
Go ahead, please.
I think you go ahead with your plan. If you succeed in the antegrade crossing, that'll be fine.
Yes.
Okay. Dr. Khanna, we'll switch to the other lab where I think George is doing a common iliac bifurcation, and we'll come back to you in a little while.
Okay.
Dr. Khanna, we are with you.
Yes.
Yes. What is the progress?
Okay. So what? Show me the last view. The progress is that what we want to do is we want to leave this wire in the false lumen, the 3-5 wire, and go with the Concrest Pro wire, because we know where we need to re-enter high above. We've got we can see the place where we need to re-enter into the true lumen, which will be high above in the distal SFA. And that is where we are going to go with the Concrest Pro wire. because it's like a wire jailing of the false lumen and then going with the coronary wire there. So this is the Conquest Pro. Go to the other view.
Just what he has suggested.
What is your view about this approach? Come, Elio. Areo.
It certainly is worth a shot, but the difficulty in these cases is, although we angiographically estimate where we have entered into the false lumen with the first wire, we may miscalculate that because, it could very well be much higher up. And even with this wire, you may still be in the false lumen. It's sometimes very difficult to differentiate at what level that you have to re-enter.
I think, sir,
correct, that's right. But what I have done is I have just jailed the previous entry into the occlusion with the wire, left the wire there, and now I'm trying with a new coronary stiff wire, CTO wire.
Sir, if you can support this CTO wire with a micro catheter, you can get a better pushability and approach.
Yes, I'm going to do that.
If this also fails, I think you can do a gentle balloon dilatation with a 4O balloon in the false lumen and break the septi, and then you may enter the true lumen again.
No. That I have already done, because I put the catheter. What I'm getting is when I'm connecting this thermo catheter without a wire to the pressure, I'm getting pressures of 110. So I've got a connection between the true and the false lumen. I just need to get back to the true lumen near the popliteal, above the popliteal, because the pressures there are quite good.
Yeah. Either you can use a microcatheter, or you can, if those balloons still exist here, we use always over-the-wire
balloons.
2 millimeter over-the-wire balloon. You can take the wire out, take small contrast
we have a microcatheter
through the center lumen, and you can easily go down the vessel. I don't know what the opinion of the panel here is, but
I have the
over years of 20, 25 years of doing this work, I've always been struck that the minute you get into the false lumen, doesn't matter what you use afterwards, drug-eluting balloon, drug-eluting stent, the risk of restenosis is extraordinarily high. I mean, the minute you start, having a significant segment of false lumen, you are pretty much almost guaranteed a restenosis that is pretty vicious. When it comes back, you'll see a very long, diffuse area that pretty much defies any treatment. So although we think that, yes, going from false lumen to true lumen and doing all of this and using a knuckled wire approach, etc., acutely, yes, it can work, but durability, to my mind at least, is very questionable.
Dr. Ayer,
but
would there be a role for coming through a collateral?
There have been trials on this.
Go ahead.
There have been trials comparing the intermediate term results with subintimal angioplasty with balloon or stent versus a luminal angioplasty, and there has not been much of a difference over a period of 1 year. I'm going to be sort of talking about this in the afternoon.
You have to come out and.
Dr. Sriram, you were asking something? Yeah.
Would there be a role for going through a collateral?
Would there be a role for?
Going through a collateral
from the profunda.
Difficult. Difficult in the periphery, unlike those retrograde approaches for the coronaries. Difficult.
I think the best would be go through the popliteal approach and through the true lumen. That would be easier and a better result.
What's that?
Prograde.
Yes, Dr. Khanna, we are with you
Got
now.
another wire? Okay, so what we have, show me the last view, play this. So we have taken a micro catheter, and what we are doing now is we have jailed the false channel with a 3-5 wire, and with the micro catheter we are advancing with the Conquest Pro.
See here in this case, one important thing to remember is this profunda artery is very important for survival of this limb, and one should not damage this profunda artery, because there are collaterals going from profunda to the femoral artery and down from the popliteal into anterior posterior tibial. So the profunda is a life-saving artery for this limb. So one should not damage the profunda artery in this case.
True.
True. I teach my fellows that profunda is the left main of the leg.
Yes.
Cannot touch it, otherwise he'll turn a stable claudication.
Seeing the patient is having the grade 2 claudication only and is not in acute limb ischemia despite total occlusion of the common femoral artery. So this profunda artery is very important. Dr. Tarun, just to say for the audience, what is your approach for puncturing the popliteal artery? Do you take the help of ultrasound? What are the landmarks? How do you do this popliteal artery puncture and do the angioplasty?
In the supine position, sir, there are two ways. One is you can locate the artery with the help of ultrasound, and then you can puncture it with either O18 needle or a long O21 needle. If you use a 18 gauge needle, you have to use either O35 wire or a O18 wire. We have V18 wire from Boston Scientific. That is very good wire to cross from retrograde.
Yes.
And second option is you inject from the top, fix the limb in RAO, LAO view, and create a road map.
Yes.
On that road map, you can puncture the artery, and then you can retrogradely advance your wire.
Yes.
And how do you close, how do you seal it?
So once you have crossed the wire, you don't put a sheath over there. And once you have exteriorized the wire, you bring a balloon from the top, keep the tip of the balloon proximal to the puncture area, remove the wire, close externally from the puncture side manually, and then cross the wire into the popliteal artery and advance the balloon. So from the inside also you inflate the balloon, and externally also you apply some manual pressure.
Yes.
4 to 5 minutes it seals.
Good. That's a very important learning point.
Yeah, I think that's really important and valuable, because the main problem in this SFA, as you saw in this case, is you can get down a fair bit of the way. It is that distal fibrous cap that is usually the real issue. Of course, as Dr. Sriram Iyer was saying, going subintimal may not be a great idea.
We've always thought about the popliteal approach as a funnel approach, The narrowest part of the funnel is on the top. And that's why to get into that spot is very difficult from when you come contralateral approach, whereas the wider portion of the funnel is on the bottom. So when you come from the popliteal, you got a big space to go inside, and then you can enter into the top.
Can you switch us to the other location in MMM? Dr. George Joseph is ready with his talk.
Okay, so
Dr. Erilin?
we are getting in with
we are
the
with you.
second wire.
Yeah?
Can we see the fluoro?
Sure. Fluoro. Switch to fluoro. Yeah. We have come with another O35 thermo floppy wire. The course seems to be a little away from the wire in the false lumen, and we'll have to confirm it.
Can we see the fluoro?
Yeah, they are seeing the fluoro.
Same. False lumen, yes.
That is the indication.
Yes.
It is in true lumen, it has restricted mobility.
This all would be a false lumen because it's a CTO. But it is catching distally, it is going into the branches. So, and if you follow it up from the top.
They are not communicating. They are not communicating.
Yeah, we will communicate at some point of time because right now we are not there where we want to be. We tried with the Conquest Pro and a micro catheter, but it doesn't advance. The wire gets bent and it doesn't advance because it's a very calcified lesion.
Dr. Khanna? Hello?
Yeah.
Yeah.
Yes.
Yeah. Yeah, I think you continue working. The organizers are telling us we are slightly behind time, so we'll go ahead with the program here. Dr. Sri Iyer will give a talk here. You continue working, and I don't know, maybe some other time you'll be able. They'll show us the final images from this case later. Okay. So yeah, all the best to you.
Okay. Very nice being with you.
Yeah.